Our next presentation will be a panel discussion. This is the first time we have tried to do this, especially for the respiratory care group. So hopefully it will be very beneficial for everyone. Our moderator today will be Zachary Gantt. Mr. Gantt is a registered respiratory therapist and entrepreneur with a passion for making a difference in the healthcare continuum. Zach will be joined by other members of the panel, and he will introduce them as they come on. R-E-S-P-C-T, find out what it means to me. R-E-S-P-C-T, take out TCP. Oh, little respect. Whoa, hey, little respect.
Hey guys,
Oh,
welcome.
thank you.
You like the virtual mask?
Hey.
I can put one on in solidarity with you if you would like.
Can never be too safe, right?
Right.
You hear me, Zach?
Yeah, I can hear you.
Can you see me?
I cannot see you.
When I hit the video, start video, it's giving me a message that says fail to start the video camera.
Huh. Okay. We may have to do it without your video. I can't see you either, Carrie.
You see me, Zach?
I can, yes.
All right.
All right. Well, thanks everybody for joining. I'm going to share my screen. And start the presentation. Okay. So thank you guys for joining. It's been an awesome day so far. Some great talks we've heard. Roger, yours was amazing a few talks ago. It was a great job. Thank you very much for just being vulnerable and talking about what it seemed like from the comments a lot of people needed to talk about. So thank you for that, Roger. We appreciate you.
You're welcome. It's been a tough year.
It definitely has. And then also a shout out to Elizabeth Anderson. That was her first presentation. So you did a great job, Elizabeth. We appreciate you joining us and look forward to many more. So today's our panel discussion. We did this in person the last couple of years at the Smoky Mountain Symposium. And so it's backed by popular demand. Everybody seemed to like it. A little bit different this year. In the past, we've done a panel where we moderated and then brought in some panelists and the audience asked questions. So this time we've got some questions queued up. But first I want to introduce the panelists. Just thought maybe we could go around the room based on the order here. So if Roger, if you could kick us off. I know we've heard from you a little bit today, but I'm just going to go through everybody introduce themselves.
Good. Thanks again. I'm Roger Richardson. I'm the manager educator at the Vanderbilt University Medical Center. And like we like to say at the Respiratory Care Enterprise, because we touch everything. And I was laughing after my last presentation because one of the questions was related to as an old therapist. So I will define myself that way. So thank you so much.
Great. I'm Dan Easley. I'm a chief strategy officer with Encore Healthcare. I've had a background mainly in devices for about 20 years, and then about 10 years or so on the provider side, a DME and a home health agency, and then lately with Encore Healthcare. So I've had a background in creating programs to manage patients in the home, and then also with some payer experience and hospital system experience as well.
And I'm Gene Gantt, CEO of Aventa LLC. And our company is involved in contracting with healthcare payers, providing population outcomes management and overseeing the 10 long-term ventilator units here in Tennessee.
Great. And then Dave Lyman, been in the DME world for about 24 years, come from the Cleveland Clinic on the acute care side, but I oversee our respiratory and our sales for the VGM group for all of the DME world.
Hi, I'm Carrie Hilton, and I am the Vice President of Clinical Operations for Encore Healthcare. And I have been in respiratory for over 20 years now. I have worked in mainly the long-term care industry for the majority of my career. And now I'm working with software to help develop respiratory therapist programs so they can improve the quality of patient care.
Thank you, guys. So just a reminder, if the audience has questions, this is really your time. So this is a time that we can just kind of sit here and chat, almost like Roger's talk, where he was got emotional and got intimate with us and was able just to kind of tell some stories. And so that's what I was hoping this time would be, is a time we could talk about some of the challenges we've had this year, talk about some of the wins we've had this year, talk about how it's really changed our industry. So we've got some questions queued up, but would love to have some questions from you guys as well. So if you want to click on the Q&A button at the bottom of the screen, feel free to add some questions as we go, and I'll check in from time to time in between questions to see if we have any. So let's get started. So the title of the panel discussion was Respect. We felt that it was pretty, with the year that we've had and the fact that respiratory therapists have really moved to the forefront of healthcare. More people today know who a respiratory therapist is than ever before. And so the title of the panel is Respect, and we've got a few questions about respect, and then we've got a few other questions that will go into home care, into telemedicine, and some of those types of things. So the first question for the panel is, how has COVID-19 affected the level of respect for respiratory therapists?
Gene, would you like me to take that?
Sure. Yeah, I didn't know which order we were going in. Sorry about that.
Yeah, whoever wants to answer. It's just an open discussion for all of us.
Okay.
Well, from my perspective, I will just share that I'm just excited to hear our name throughout the national media, even though that I bashed the national media earlier in my presentation because of the misinformation and some of the false information. But it was not uncommon for you to turn on some of the news channels and hear the phrase doctors, nurses, and respiratory therapists all together. So I think that's just elevated us to a higher level. But I have in front of me a comparative perspective slide that I presented last year on ethics. And if you just will take a step back and remember that the American Association of Respiratory Care, the AART, is really a very young organization as compared to other health professions. And you can't really compare it to nursing or MDs that have been around for a couple of centuries. In fact, it was 1900 when nursing really kind of kicked off. And by 1920, every state in the Union, at that time, the 48 states had licensure. We didn't get licensure for all of our 48 states until 2000. So I think we have some catch up to do. And unfortunately, this pandemic has just brought it to the forefront. But as I believe that we have just been the silent warriors and perform miracles every day as part of the healthcare team. So I think the respect on an individual basis is always earned by the nursing staff or the medical staff on the organization that they work in. But we just have not done a very good job as a profession coming together and supporting our profession. And one of those ways is to join the AARC. There is just power in numbers. And when only 1/10 or 1/20th or whatever you're going to measure it, pay the 28 cents a day to join that's nothing. That's 28 cents a day. It's all it costs. And if you're not willing to do that for your profession, I think you need to maybe find a different profession. So, but I think COVID has brought great respect to us, but we've also earned it through the life-saving techniques and talents that we hold.
Yeah, thank you, Roger. That's great points, and I think we all know that we're big proponents of supporting the AARC and our profession, and thank you for that. Anybody else want to comment on that question?
Yeah, I'll jump in since I missed my first shot. Thanks, Roger. For us, the respect level is out the roof in our particular arena because of our relationship with TennCare and with the payers across the state. When COVID became an issue in the skilled nursing facilities, they tapped us to come up with a plan to actually develop sites that were COVID specific, nursing homes that were COVID specific. So we were able to do that, and as a result of that, we now oversee the program as well for the Tennessee Department of Health in partnership with TennCare and the other payers. So we were already enjoying a good level of respect in Tennessee. I can tell you from the state perspective, the Bureau of TennCare, Department of Health, they have great respect for respiratory therapists even prior to COVID. But now that COVID is here, we really have their attention. So it's been very interesting for us to see what happened in the last couple of months. But it's affected everything we do, obviously, and it can be better from a level of perspective for us.
I just want to say that I'm so appreciative of the fact that I guarantee I will never be asked again. Did you have to go to school to be a respiratory therapist? I think people know now.
Yeah.
Yeah, and Zach, I think just to add from the whole medical equipment, from going into patients' homes, now a lot of telehealth videos being done or education by the DME providers. I think in the past, the question was, what is a respiratory therapist? Kind of what Carrie was saying. Well, what do you do? And I think that it's brought more awareness to the world of what respiratory therapists do and how we can have an impact in people's lives every day.
Yeah, that's right. Well, we have a couple questions coming in from the audience, so I'm going to go ahead and ask those live here to the panelists. So the first one is for Gene or Roger. Are we working towards a compact licensure for respiratory?
Gene, I'll take that. I
Yes.
know that there's just been talk. I don't think there's anything at our state level from our state board, and I'm fortunate to have an office next to Craig Rooks, who's on the board, and so I get updates after each of the board meetings, even though they're open to the public. I've not made it, but I don't think that's been an issue or been brought to the forefront as something that we need to do. Post COVID-19, I think there will be. So Gene, what are your thoughts on that? The nursing world is pushing for it very strongly, so hopefully we'll fall on the coattails of that.
Yeah, I see a lot of discussion about having a pact like that so that we can travel across state lines, things of that nature. But that's not an easy accomplishment because of the fact that in each state, you have to deal with respiratory care boards and licensing situations, and it's always different from state to state. So it's not something so much that the AERC or the TSRC can just say, hey, we want to have a compact with you in Arkansas. It doesn't work like that. So the whole process that nursing went through was years and years in the making. And for us to do it, we have to get started. It's a great thing, and we should start it. And maybe this year will be the year that we can see some movement on it. But because of the different various governments that are involved, it does become quite an issue and problem.
Thank you, Roger. Thank you, Gene. Another question we've got here: what impact has COVID had on continuing education for RT staff? And I think that it's really state by state specific. Most states have waived some form or fashion of CE requirements. Some have waived just the live requirement. So you really would have to go to your state website and look that up to be able to identify what your state has done. And it's still kind of confusing, I think, because some of those memos, we've had trouble trying to decipher those, trying to figure out what's still required, what's not required, how long is it waived for. I think in Tennessee it was waived till October. And so I think that's one of those things we're all still trying to decipher at this point. The next question is, due to the new recognition for respiratory care, due to COVID, will it lead to better utilization of respiratory therapists in different fields? It seems we only do a fraction of what we are capable of doing in some settings.
I'd like to take that, and I don't want to monopolize the conversation here, but once again, that is a licensure scope of practice type of question, and I think it's a great question. And if you look at the Tennessee's Practice Act, it's very broad, and I think we have support from the board to do things as we do, but it also will fall under the scope and practice of a licensed physician. So if the physician is doing a procedure that has a billable code for CMS, that's indirect or direct supervision, there's nothing that would stop a respiratory therapist from performing that particular task. And I think if we can follow the CARES legislation on telehealth, and maybe we'll get to those questions, that's a really positive advancement for our profession and for those practitioners who want to work in alternate sites outside of the academic centers. So.
Thank you, Roger. I'm going to go back to the questions on the screen here for a second. We'll wait and see if a few more questions come in. So this question, I've got hospital on here, but really I'd like to ask it to everybody. And the question is, how are your respiratory therapists? I know this is a tough year for everybody outside of the medical field, but especially those who are respiratory therapists, the nurses. I see a lot of people posting on social media that they're tired, that they're wore out, they're exhausted. And so I'd just like to hear from you guys. How are your respiratory therapists that work alongside of you or work for you? What's their attitudes and how are they doing?
I can start with this one. I know that we've been hit very hard with our staff, but they've all maintained such a positive attitude, and they are tired. They've all been working a lot of hours, but they are just so dedicated and think about the patient first, and they're all very supportive of each other, and I think it's unified us even more. We've always had a great team, but I think it's brought us all together. It makes everybody feel like they're fighting the same kind of battle every day.
Yeah, and I'll say our therapists are doing very well as well. They have a real commitment to their work. I think the thing that frustrates them most is that they can't do more right now. We flipped a switch and went with all telehealth at the onset of the COVID virus becoming a pandemic. And it's again, just frustrating that, what can we do aside from this? So we've had to work a lot harder to bring in resources to help people in their homes that are homebound. We've had to work harder to keep the respiratory therapists safe that are working in ventilator units across the state. So far, we've been very, very fortunate. And in our population outcomes management program, for example, out of 800 patients, we only had a total of about 10 who were affected by COVID because we were able to get resources for them, bringing food in, making sure they had coverage for other needs. So that's the only thing about our people is that they are wanting to do more and they wish they could.
Yeah, and what I'm seeing out there with the therapists, some of them are tired. Depends on what part of the country you're in. There is a shortage of respiratory therapists out there. I'm seeing a lot of the DME providers. The hospitals are recruiting the therapists, so they're going back to the hospital, and so there's a shortage in the field. And the other thing with the DME providers out there, Zach, is they're used to seeing their patients, so now they're doing it remotely, a telehealth. So it isn't as personable. You're not there touching the equipment, right? You're not sitting there with the caregiver or the patient, having those in-depth discussions with the patient, whether it's their disease state, whether it's their equipment. So I think that some therapists out there are struggling. I believe that they have stepped up to the plate, and I attribute that to respiratory therapists training, schooling, being involved, like you said, with state association, being involved with the AARC. It's important. And I think everybody, just not respiratory therapists, this has been a tough year, not getting that personal touch with people.
Yeah, it's a good point, Dave.
Zach, before we leave that topic, may I add something to that from a hospital end-of-life standpoint? I think, as I talked in my presentation earlier about the workload and the volumes, and tremendous amount of stress that practitioners have been under, from a clinical standpoint, they've managed it quite well. I think the surprise was the emotional toll this has taken on them. We have seen so much end of life as an example where we had a husband, wife, 82, 84, on our COVID ICU, separate rooms. The family made the decision, we want to put mom and dad together and in life support. That was hard. So those are the type of situations that, even though we face life and death every day, it's just been highly emotional. And I think for any respiratory therapist that has the ability to use an employee assistance, an EPA type of service, and get some counseling. Don't take any shame in that. I've just cried on, I've just broke down over it, and I've never been that kind of guy as far as when it comes to work. You just compartmentalize that and you just push forward. So maybe part of it is my maturity, but part of it may be that this is a very unique time that none of us have gone through in our history. So our therapists buckled from the workload. It's the emotional toll that's been so interesting. And I think that's when we define, we've got to get people out of their fear zone and get them the professional counseling that is needed. So thank you.
Thank you, Roger. Gene, we've got a follow-up question for you, which is that you mentioned there are COVID-specific long-term care nursing homes in Tennessee. Where are those located at?
There's quite a few, so it'd take a little while to list them all, but I know there's, in each grand division we have one at this point, in Upper East Tennessee, Chattanooga, Knoxville is getting ready to open. They're not open yet. And in Memphis, they're up and running. We're adding those on as the volume is needed. And they have to meet a lot of specific requirements. And one of those requirements is that they have to have a respiratory therapist on their unit. So for any COVID unit that's approved by the state as a specific unit, they have to meet those minimum requirements. Respiratory therapists monitoring things that we normally would do in a higher level of care, usually not in a skilled nursing facility. At this point, I'd be glad to send some names so you can get those to them. But they're still being added on to as we speak.
Okay. We're going to switch over to a skilled nursing facility question or two, and then into home care and telehealth, and then we'll continue to answer some of the questions from the audience as well. So how has COVID-19 affected respiratory care in the SNF? I know that we've seen some SNFs who have brought in respiratory therapists to help manage COVID patients. We've seen some that have downsized. So just overall, maybe Carrie could start this one, or Gene. How have you seen respiratory care be affected in the skilled nursing facilities since COVID? And really, how are those therapists doing in that environment?
Ladies first, go ahead, Carrie.
Thank you, Gene. I think that before COVID, we were always trying to focus on kind of preventative measures with our patients, but I think that it's took an even bigger focus now, and the nurses have really gained a whole different type of respect for us. Before, it was always like, why aren't you doing my breathing treatments? Why aren't you doing my breathing treatments? And now it's completely different. They want you to assess the patients, not just our COVID positive patients, but there's just a whole different level of respect for not only us, but our profession. And now they will definitely take, when we order incentive spirometries, we don't have that. Oh, really? I mean, it's definitely, they understand now the importance of the preventative care that we've been trying to provide this whole time. And of course, when, we're working in our COVID side, respiratory, they just really depend on the respiratory therapist now. And it's really brought them a lot together. They're much more of a team, and instead of like a respiratory here, I have to move out of the way. We're much more of a partnership now in all of our locations because of that. The treatment plans that we've been able to do, it's changed a lot because certain equipment, is definitely different. You don't want to be using things to induce cough and spread COVID when we do have a COVID unit, but we've increased a lot of our vest treatments. We have our patients wear a mask, and we have a lot of vest treatments. I think as a whole, we have over 40 patients on vest treatments now, and those numbers grow every day. And that's a difference that we've had. We've always been a big proponent of vest and cough assist therapy, but now those numbers have definitely started doubling.
And I would agree with what Carrie said. Very good points made. We've seen a big uptick in the utilization of respiratory therapists, not only in those sites I was mentioning, but we know of several COVID outbreaks that have happened across the state that they voluntarily brought in respiratory therapists to help. So the spotlight has been on us in this particular arena. And as we unfortunately know, it's not going to go away for a while. So we still have some work to do.
Thank you, Gene and Carrie. Okay, so Gene, this one's probably more for you. How has COVID changed the dynamic of skilled nursing facilities and LTACs? Have you seen any kind of changes in the ventilator unit side of things that you guys help to manage or oversee? And then what about LTACs?
There's not been a lot of change as far as the dynamics of the patient coming in, but of course the dynamics of the patients once they get there are a whole different story. We've been, again, very fortunate not to have any outbreaks within those units. Those employees are monitored very carefully. If there's any sign or any question, then they are tested, of course, and in the nursing home world, skilled nursing facility world, you're tested quite often, as y'all know. So it's changed the dynamics of care. It's changed the procedures that are being done and how they're being done. So we have to be much more careful with droplet considerations, things like that. The LTACs, I understand, are bearing a little bit different brunt, and they're receiving quite a few more patients than the skilled nursing facility. We have not yet had a situation where we've had a COVID positive patient or somebody who is in recovery phase but still ventilated admitted to any of these units, but we do anticipate that. And in fact, we built into the state plan a secondary tier for COVID specific sites to include a ventilator site if needed. Thank goodness it's not been needed yet. So the fact that they're having to gown up and robe up in all these patients, we're very protective of these patients. So the fact that we have a lot of time spent doing that and focusing on infection control is a big change as well. Always been focused on it, but right now, as you know, it's like you gotta have a laser focus on it.
Thank you, Gene. Okay, let's move on to telehealth. So telehealth has really moved to the forefront for respiratory therapy, respiratory care. I think both from a perspective of home care, we've also seen that in sleep medicine. We've seen that some in skilled nursing facilities, and then even with Aventa with oversight for patients in the home as well as patients in facilities. So I'd just like to hear from some of you guys. What have you seen with the shift towards telehealth? And do we think that that's here to stay, or is it going to be a temporary shift just during the pandemic?
Well, as I mentioned earlier, we saw a 100% shift in our population that we were seeing in the home setting. It has been widely accepted by the patients. I think they like it a lot more than us coming to knock on their door and try to take an hour of their time and teach them something. They actually, we talk to them a lot more now. They know how to get a hold of us as well as we know how to get a hold of them. So in the time when they're quarantined, they need somebody to talk to. So we've been able to become a sounding board of sorts too, and take care of some mental health issues as respiratory therapists. But telehealth has been a big boom for us, made us much more productive, and it's been well accepted by the payers, by the state. I don't anticipate it's going to go away. I think there'll be, more hands-on once we can get back in and start doing the hands-on. But I think the telehealth piece is definitely here to stay.
I agree. I think patients are a lot more conscious now of having people in their home and of infection control risk and that the risk that they are under with their disease process. So I think that they definitely will want to have more telehealth visits, and I don't think it'll ever replace hands-on because you just can't. But I do think that more patients will be more precautious and they'll want therapists to do more telemed visits and less in-person visits. And with the improvements in technology, especially like modems with the ventilators and things like that now, that's a lot more capable of being able to do that now.
Carrie, thank you. This is Roger. I want to agree with that. I think it's here to stay. Vanderbilt rolled up very, very quickly a new process for telehealth, and it has been widely adopted by the community. And I know Dave said has a history with the Cleveland Clinic, but in a previous life, I did as well on an outskirt of a project. And this was 7 or 8 years ago. And the stats were telling us there when we started doing telehealth with iPhones that most seniors would adopt it quicker. In fact, the research showed that individuals 55 and over used 5 apps a day on average. And I would be working with the Cleveland Clinic, and they would come in, the seniors would come in with the newest iPhone showing pictures of their great grandchildren, and they adopted it very quickly. So I think the falsehood that technology is generationally defined is false. And I think you're going to find most individuals, when they get comfortable with it, use telehealth. And I know that here at Vanderbilt, we have shifted that way, and it's going to get some opportunity for our respiratory therapists. So thank you.
And it's one other comment there. I agree with what you're saying. Is one other comment that I gotta pull out is that we've been trying to get telemedicine accepted for years and years and years, and it took something like a pandemic for it all of a sudden to click into play, and now it's okay with everybody. I don't know if any of y'all had your experience with telehealth yourself, but all of our telehealth visits from our physicians are now are done by telehealth. I hadn't been to a doctor's office all year. It's pretty cool.
Yeah, and just to add, I definitely think telehealth's here to stay. You can just see it just by CMS. CMS is adding CPT codes. They're decreasing what you need. It started with the chronic care management, right, in 2015, where you had to have, for physicians to do some telehealth. They've reduced that to one chronic care condition, and they're reducing some of the limitations with telehealth. I think it does well. I'm hearing some of the providers now. Obviously, this is a less acute therapy, but we're hearing like CPAP setups. The providers out there that are using telehealth setups, it's too early to tell, but what we're hearing is their compliance rates with their patients are much greater. So is that because of the pandemic? I'm sure that has something to do with it, but patients seem to be more inapt to listen through a telehealth type service, kind of like Gene said before, than having that you come out to their home. So I think it's here for long term.
Yeah, I would chime in too that I think what it's also done is stretch the home RT skill base into really assessing and understanding what a patient's telling them, much like Dr. Seifer talked about today with some of the dynamic dialogue feedback in terms of what are you really telling me. So it's stretched some of the skills there. It's not all about just understanding the device and the numbers coming from that device, which is a really good thing because I think it's going to continue to stay. Which also opens up some opportunities for new relationships with the physician offices. And we saw in June that the physician traffic had gone down by about 50%. By the end of September, that might have gotten back up to about 80%. But the fact of the matter is they're not seeing as many of these patients, nor do they also have the amount of time to spend with those patients that a home RT could spend with that patient and really sift through what a patient's telling them. So in all these types of issues, there's always a silver lining. And I think we'll see that silver lining in 2021 here.
Yeah, I agree, Dan. Guys, I'm trying to keep up with the questions on the chat and the question answer. We've got quite a few. One that I think is pretty important, but I'm just going to preface it by saying that we're not going to talk any politics on this call. But I think it's an important question, and that is, if a COVID vaccine comes out in 2021, what's your opinion about taking the vaccine? And I just want to answer that myself real quick and say that we are in the business of science. And if we believe everything that we do as respiratory therapists, which all came about by science, then I believe that we should be the first ones to be in support of a vaccine because the science has worked all these years for us. And so why would it fail now? So I would just say for me personally, I think that we should be proponents as scientists ourselves of something that's been scientifically proven much faster than maybe in the past. But I do believe that it is our job as clinicians to be on the forefront of science, and that's what's happening with this vaccine. So just my opinion. I'll let anybody else chime in there.
Amen, brother. Just amen.
I'm already in line.
I can't share with you because of, I mentioned in joking at the end of my presentation that Dolly Parton, I'm going to find her here at Vanderbilt one day and bring her to this conference because she gave $1 million in April, anonymous. I mean, it's been public now to help with Madeire's research here that's actually done at Vanderbilt. And that signs, I trust these people with my lives. And I'm just want to say, amen, Zach. We'll trust the science and go with it. Thank you.
I agree.
Okay, well, let's talk about home care for a second. So on the home care side, we've talked a little bit about how it's changed strategies, but I'd love to hear from Dave, Dan, Carrie about really what's your perspective of how the strategy change has happened, especially with the more complex patients like ventilator patients. What does that look like? I know that we've not seen a ton of adoption to telehealth, but we have definitely seen some changes in strategy. So I'd love to hear from you guys on what that looks like.
I guess, Zach, I'll jump in and start with it. I think the strategy is, it's kind of like you said, it's, you have a complex respiratory patient, they're on ventilation. How are you going to do that telehealth call? How are you going to go see those patients? What if they need you, et cetera? So I think the strategy's changed where some of these patients that have been on ventilation, we'll pick on the invasive patient for quite a while. The telehealth strategy is working because it's having more conversations with the caregiver or caregivers to discuss with the patients, making sure they're getting the equipment that they need, the soft goods that go along with the ventilator, right? And the biggest thing that's changed, we're talking ventilators, is there's a shortage on circuits, there's a shortage on HEPA filters, et cetera. It's not necessarily easy to get all of the soft goods that they need. So fortunately, some of the manufacturers have come out with cleaning techniques for circuits, et cetera. So that's really has changed, what folks are doing in the home. And I think we're going to continue to see that shortage on disposables as time goes on. I don't see an end any time in the near future. But I think it's really the strategy of identifying what patients could be seen just as effectively remotely and what patients you still have to see. And the changes that really, Zach, that are major that have happened, it's pretty self-explanatory. You've got a gown up now, you got a glove up, you got a mask, you got to put a shield on. So it's a lot more precautions than maybe in the past that has been done. But there definitely has been a significance of change, but I think using technology will help better assess where to determine to put your clinical resources with these patients.
And just from a clinician standpoint, talking to many of my customers, their on-call has changed because patients are a lot more conscious of not wanting to go to the hospital, so they're trying to stay home more. So they'll call about being, more sick than just equipment issues. So a lot of the call has changed, and the therapists have a much more appreciation in the homes too, because the patients will call in and say, I want to talk to my respiratory therapist. My breathing is bad now. I mean, you hear these kinds of stories over and over from our customers, and that's just amazing to me, because I was in home care and on call, and I just got called because the machine was beeping. And so now to finally hear patients who are educated enough to know, you need to stay home if you can, call us, let us help you, reach out to your physician so that you don't have to always run to the ER. We can help you. So I think that is a very different shift that we've been seeing in on call. And I think it's a great improvement.
Thank you, guys. So one more question from the audience here. We've got about 6 or 7 minutes left. How do you think the pandemic is going to impact the respiratory therapy field in the next 5 years? So where do you see us in the next 5 years? And what are we going to look like in 5 years from now?
Well, I'll take that because hope springs eternal. I'm very encouraged by the educational path that some of our universities are doing for an advanced practitioner to be equal to a nurse practitioner. And I think we'll eventually get there. But that is a single path that will go nowhere unless we work as a team from a legislative standpoint, because as Jean had mentioned, we have multiple states with different types of licensure laws. And unless you have a state license to practice at a higher level, it's going to do you no good to have that advanced education. So that's where I see us going is in the entire profession. And Zach, it matches up with what you were saying about trusting the science. So the more times we can get an RT's name in a peer review article, the more times that we can get recognized at the policy level, at the government level, at the public relations level. And I think we've been silent warriors and just gone about our business for 20 years as silent warriors. But now it's time to beat our chest a little bit and take pride, as we've always done. And I have been extremely proud of being an RT. And I just see a comment that came across that someone said, don't forget CRTs are RTs too. I totally honor that, totally get that. And I think we've changed the licensure law to call it certified respiratory practitioner versus CRT. I think that's good. I can tell you, as a new entry into the legal profession is where the medicine profession was about 25 years ago, where you really only had a nurse and a doctor, and then everybody else was garbage in there. And some of the state licensures that we've gotten pushed back for someone with my kind of law degree is they want to call you not a lawyer, they would call me a legal technician. I take great offense to that. Technician, not to put anybody down, and I have a son that's a master mechanic technician. I'm very proud of him, but he's skilled with his hands, and we need that in the country. But it's not equivalent to a professional degree from an academic standpoint. So that's just a very interesting thing. So anytime that we are put back into that technician box, I would fight it tooth and nail. Don't mean to get passionate there, Zach. I'm sorry.
Oh, that's good.
I cry and get mad evidently on the same day. So.
So Dave Lyman, there's a follow-up question. Is there anything being done about the supply shortage issue in home care and really in the hospital as well? Do you know of anything that's being done to address that? And where are we at with that issue?
Yeah, it's a great question. It all starts with supply chain. And unfortunately, a lot of these plastics, the medical grade plastics, the beads that start the plastic that go into the injection mold machine, they're in China or other countries. So there's a shortage of that. So it all really starts with the basics in the beginning. I can tell you, I'm going to speak for the in the sleep and ventilation world. We'll talk about the two big R's. I know that they're doing everything in their power and trying to source other manufacturing, whether it's in Mexico or Vietnam or even in America. They're trying to find companies. I'll pick on a Pepper Medical, for example, in Philadelphia, Pennsylvania. They're producing HEPA filters and doing some other filtrations that they normally didn't do in the past. And they're making them here in the United States, which is obviously increasing costs, but it's going to help with the long-term demand. But I can tell you that everybody is working on it. There's nobody that is like, gee, we're short, no big deal. Not the case. It's the sourcing of the medical grade plastics is really what it comes down to from the injection mold machines. It's just like gloves. I've even been speaking to some of the distributors, and they're telling me that the shortage of gloves is going to continue, and gowns. And unfortunately, it's just we don't have enough manufacturing of these products. So I wish I could give you a better answer, but our partners and the manufacturers out there, they are doing everything possible to really help with that supply chain piece.
Thank you, Dave. So we are out of time. We've got about 2 minutes left. So just some closing remarks. We had a lot of questions in the chat and in the question and answer. We didn't get to all of them, so I'm sorry about that. Next time we'll schedule more time for the panel discussion. This was a lot of fun. I hope you guys enjoyed it. I do want to say that that the thing that stood out to me the most is just that there's a lot of people out there that are scared, a lot of people out there that are wore out, frustrated, and that are working hard to save lives. And so I just want to say thank you guys from the bottom of my heart. I want to ask everybody if they pray for the rest of the respiratory therapists. And again, just thank you guys for what you're doing. We're so proud to be part of this profession. I speak for myself and our team that I've never been prouder to be a respiratory therapist. So thank you for that. Thank you, guys.
Thank you.
Thank you.
Thank you.
See ya.
I did.